Okay. So boleh start lah. Dah ada 9 ke 10?
10.
Oh, 10. Okay. Make sure hari tu kata 2 slides kan? Banyak ni.
Ada yang saya tak present.
Okay, tapi 2 slides so maximum okay, kalau 1 10 minit, kalau 10 100 minit, 1 minit dah sejam setengah, sejam 40. Okay lah, maksimum 10 minit termasuk Q&A.
Okay.
Okay.
Alright.
Lepas tu later you guys share lah the slides. So the focus is apa yang you tak faham. Okay, you just tunjuk the slides and then present the important things and then you akan the rest tanyalah anything yang you tak faham. Okay, because anyway benda ni macam more you need hands on lah rather than listen. Okay. Start.
Right. Can I start now, Doctor?
Yep.
Okay. So I start now. So Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nurina Nabila. Today I'm going to present about endotracheal intubation. So this is my presentation outline. That's a lot, but I just going to present just briefly, okay? So as you know, endotracheal intubation is a placement of a tube into the trachea. It can be either orally or nasally for airway management, but the most common one is used orally instead of nasally. This is indications and contraindications of this procedure based on PITS protocol. So indications of these procedures is when back and mask ventilation or continuous positive airway pressure is insufficient, for prolonged positive pressure ventilation, direct suctioning of the trachea to maintain and protecting the airway, and in case of newborn for diaphragmatic hernia. But this procedure is contraindicated for those who is inexperienced of intubation. So what should they do is they should perform back and mask ventilation until the help arrives. So certain anatomical importance of neonates. Before doing these procedures, we should note that the airway in neonates are much smaller and shorter in length. The tongue is much larger. The epiglottis is quite long, floppy, instead of rather than adults. The funnel-shaped larynx in children, ankle vocal cords, short and flexible trachea. So this is the picture that I've mentioned before. You can view it. This, okay. And then equipment that we need. The first one is endotracheal tube. So the one that is preferred in young infants and young children is the uncuffed tube, because if we use the cuffed tube, we afraid that it will make a mucosal injury, tissue edema, and also fibrosis that will then lead to a life-threatening condition. So certain age of children have certain size and length of ET tube that should be used. So this is I included the calculation that's needed to know the size and the length of the ET tube. And then the radioscope, blade, we have Mac and Miller blade. For the one that preferred for infants and young children is Miller blade, which is the straighter one. The Mac one is used for adult and also older children. And then this is the equipment, other equipment that needed. Okay, you can read it. Okay, so for the mask, we have to choose the right size of the mask, and also we have to position the mask correctly so that there will be no air leakage around the nose and also around the chin. Okay, so how do we do that is by pulling the jaw forward towards the mask with the finger of the hand holding the mask, but please do not hyperextend the neck because it can damage the airway of the neonates. So for preparation, we need informed consent, which means we have to tell the guardian what we want to do, why, and maybe explain if there is any possible complications during the procedures that might happen. And then preparation of materials, monitor the vital signs, ECG monitoring, and so on. And then airway evaluation, sniffing position, sedation, and neuromuscular blockade. So for airway evaluation, there's 2 mnemonic that I put in this slide. So you can read it later. It's quite simple. You can understand it, okay? The first one is lemon. This is to assess airway and predict difficulty during intubation. You can read it after this. And then the other one is SOMI. This is quite simple because it is used for throughout the procedure. So for sniffing position, there is 3 criteria that we should note it. Okay, so the first one, the glabella, which is the area between the eyebrow, should be horizontally aligned with chin plane, and then the neck should be wide and open. And then the third one is external auditory meatus should be horizontally aligned with suprasternal notch plane. And the one that we should adjust is the headrest, maybe could be higher or lower to meet these 3 criteria. And also shoulder roll. It's kind of similar with infants, toddler, and also older children. Okay. So the procedure of this, the step to do this intubation. So first one, with your right hand, tilt the patient's head back while lifting the chin, as you can see in the picture, and then opens the patient mouth by pushing the lower jaw with thumb and pushing upper jaw with your index finger. And then with your left hand, you have to insert the laryngoscope from left side of the patient's mouth, moving aside the tongue and locating epiglottis. So as you can see, there is 2 types of blade I've mentioned before, right? So for the Macintosh blade, the curved one, it is we use by inserting the blade between the tongue and also vallicula. While for the straighter blade, the Miller blade, we insert the blade on top of epiglottis because in children, the epiglottis is long, floppy, and narrow, right? So if we insert it the right way, then we can view it. We can view the airway easily. Okay, the next one, after you have inserted a laryngoscope, you have to push it, adjust it by pushing forward and upward to lift epiglottis and view the trachea and vocal cord. But please don't pull it backward because it can risk injury to patient's teeth. And then if necessary, you can perform Selig maneuver where you apply pressure on the cricoid cartilage to reduce regurgitation and helps bringing vocal cords into view, as you can see in the picture. And then you can insert the lubricated endotracheal tube via the right side of the mouth so that you do not obstruct your viewing area, which is the left side. And then after you've inserted, the tube should be inserted approximately 2 cm past the vocal cord, roughly at the level of thyroid gland. And in case if intubation is not done within 20 seconds, you have to stop the procedure first, and then you have to reventilate the patient with bag and mask ventilation. Then you have to repeat back the intubation process. Okay, and then while holding the ET tube in place, remove the laryngoscope, and then you can pull the stylet from the inside of ET tube. So in case of cuff, if the cuff tube is being used, you have to inflate the tube with empty syringe. But if in case of uncuff, you don't have to. Then right after that, you can attach the end-tidal carbon dioxide detector and empty back to the ET tube. And then you have to squeeze the bag at regular intervals to begin ventilation. So if the detector turns into gold, it means that the tube is ventilating the lung, which means it's good lah, kan? And then you have to check for bilateral lung inflation. Check for if there is, if chest rise is present, so you know that the procedure. So you know that you're doing the procedure correctly. So finally, you can secure the ET tube with tape and attach the ventilator to empty bag. So additionally, from a PITS protocol that I found, last step you want to confirm the placement of ET tube, you can do chest X-ray. And another one, look for chest expansion. Okay. So last part is the complications for this procedure. So the first one is esophageal intubation, and then right lung intubation. Why right lung is because right lung is much wider and shorter, so that's why things are more easy to get into there instead of left lung. And then trauma to the upper airway, subcutaneous stenosis, which presented late. And the last one is pneumothorax. So that's it. This is my reference. And also I've included a link for a video if you want to see it. Okay, that's it for my presentation. Thank you. Any question?
Very good, very good. So it's on time. Okay, tak apa, you boleh bernafas. Okay. So any questions? This is very, 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 very important procedure. In fact, I think this is the most important life-saving procedure yang we're going to present. Any questions? It's difficult though, especially in pediatric. It's very difficult. In neonate, it's not that difficult to intubate, but in pediatric, it's difficult because neonates, the trachea is very soft. But in pediatric, it's tougher though. It's tougher. So less space for manipulation. So any questions and more risk of complication. So any questions? So in general, we no longer use nasal intubation. In fact, nasal intubation is quite easy, and is less risk of esophageal intubation lah. Tapi you need equipment, you need to use the crocodile clamp ke benda nama saya tak ingat lah. Okay, ada soalan? Okay, kalau tak ada, next. But if you got questions kan, guys, if you got questions, you can always ask me or ask the presenter lah later. And make sure you view the slides and the video, because this can come out in your exam, okay? And definitely we're going to ask you the theory of the procedure during your clinical assessment. Okay, proceed.
Okay, you guys hear me?
Yes.
Okay, so Bismillahirrahmanirrahim. I will be presenting about the hand hygiene and personal protective equipment or PPE. So next. Next, I think there is a problem here. Okay, so hand hygiene is any action of hygienic hand antisepsis in order to reduce transient microbial flora. And it is important to reduce the transmission of microorganisms, to create a safer working environment for the medical staff and the patients, and to decrease the healthcare associated infection. So next. So this is the 5 moments of hand hygiene. So the first one is before touching a patient. The next one is before clean or accepting the procedure. The third one is after body fluid exposure risk. The fourth one is after touching a patient, and the last one is after touching the patient surrounding. And hand hygiene, it must be performed in all indications that described, regardless of whether gloves are used or not. Next. So this is basically the poster to how to hand rub and how to hand wash. So when there is visible soil, hand wash is needed, and hand rub is the best alternative if water and soap is not available. But hand washing is highly recommended hand hygiene practices, as it can reduce illness in people with weakened immune system by 58%. So next is personal protective equipment or PPE. It is equipment to protect the user against any hazard and risk in the healthcare setting. And there are many types of PPE. So next. So the first one is mask, and it is used for 3 primary purposes, which are to protect the healthcare workers from the contact with infectious material from the patient, and vice versa. And the next one is it is placed on the patient to limit potential dissemination from the patient to environment. And as we there are 2 types of masks. So the next one is glove. So there are also 2 types of glove, which are sterile, used when performing invasive medical or surgical procedure. The next one is non-sterile glove.
it is used for protection against blood and body fluid when performing routine patient care. And why we have to wear gloves is to prevent microorganisms that being carried on the healthcare worker hands from being transmitted to the patient and from the patient to another patient. And it also to reduce the risk of healthcare worker acquiring infection from the patient. So next is gowns or plastic aprons. So gowns is used to prevent contamination of the arms, exposed areas of the body, and clothing from blood and body fluid and other potentially infectious material. And it is used during standard precaution. For the plastic apron, it is to provide a waterproof barrier along the front of the body and to protect the skin from contamination with blood and other body fluid. And also used during standard precaution. And if there is any suspected or confirmed infectious agent, it has to be worn together with the isolation gowns. Next is protective eyewear, such as goggles, face shield, and safety glasses. This protective eyewear prevent any splashes or sprays of blood, body fluids, secretion, or excretion, as infectious agent may enter through the mucous membrane of the eyes, and it needed during standard contact, droplet, or airborne precaution. So next is head cover or hijab cover. It is to keep the hair, beard, or scalp from contaminating the sterile area. And it usually for any surgical or procedure when a sterile field is necessary, and it is not a routine PPE. So the next one is footwear, such as rubber boots or shoe cover. It is used to prevent microorganisms from contaminating the foot, and also prevent transmission to other patients. And it is used during the procedure that involve the possibility of excessive blood and fluid. So next, so this is example of the how to wear the PPE. So the first one is PPE level 1. So it is used when there is no suspected or known infectious agent. And what to wear? So what to wear is surgical mask, glove, plastic apron, goggle or full face visor if there is anticipated exposure to blood or body fluid. For PPE level 2, which is contact or droplet, it is used when suspected or confirmed is infectious agent that spread by the direct or indirect contact or droplet. And it includes the surgical face mask, goggle or full face visor, full body gown, plastic apron, and glove. For PPE level 2, which is airborne, it is used when suspected or confirmed is infectious disease of high consequences. And what to wear? It is included N95 mask, head cover, boot or shoes cover, glove, which is double glove, full body gown, plastic apron, goggle, and full face visor or a full face visor. So next. So this is my references. I will provide the video how to don and how to doff the PPE in the WhatsApp group. So that's all from me. Is there any question?
I have a question. Why is it important to wear 2 layers of gloves for airborne PPE?
Because the disease is infectious disease of high consequences. So we don't want, we have to like double the protection. Is that answer your question?
Thank you, Afika.
I don't think that's quite right. I think I don't know, but I think that's not quite right. We use double because the first glove is actually for us to wear the PPE. No. And then so there's risk of contamination. Because the first step is you wear the glove and then you wear the rest kan. Betul tak? Kan?
Okay, okay.
So
Sorry.
you wear the glove and then you
Oh.
wear the rest of the PPE, which is not sterile. Then of course you're going to contaminate the glove. So that's why you need another glove. Which is again saya rasa memang bazir, tapi that's how we do it lah. And then you need to know the level of gloves tau. Dia ada level 1, level of PPE, level 1, level 2, level 3 and so on. Tahu kan?
Okay.
Okay. Because
Yang
later kalau
saya present tu doktor.
dia ada level 1 PPE is level 1 is the I always mix out. I rasa macam level 1 tu is the strictest, the most strict. So level 1 is the whole PPE, you know, with the face shield, everything. That's level 1. Level 2 is level 2 is without the full sterile PPE macam astronaut tu. Tu level 2. Level 3 is just glove. Glove alone. Macam tu the glove and I think glove alone is level 2. Level 3. Yang tu you check lah. So later bila you masuk assessment dia kata, okay, you need to wear level 2 or level 1. So nanti you kena jangan salah ha.
Okay. Okay, Doctor, thank you.
Okay, any other questions? Okay, ni kan Datuk ni. This is level ni ada level 1, level 2 ni ada. Okay, good. Okay, next.
Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. My name is Nur Iza Zahira binti Zamri, and today I will present regarding the height, weight, and occipitofrontal circumference in pediatrics patients. Okay, so for the height and the weight, we divide it into two groups, which is less than 2 years and more than 2 years. So for children under less than 2 years, we measure the length instead of the height because they cannot stand yet, and we measure it using a measuring board from the top of their head until the end of the feet. And for 2 years, for more than 2 years, we use a stadiometer where the child can stand, and we proceed with 3 measurements, and we pick an average between the 3 measurements. For the weight, for children less than 2 years, we use a calibrated weighing scale. For example, we put the baby on top of the weighing scale, and we take 3 measurements as well, and we divide it for the 3 measurements to get an average. For children more than 2 years, we put them on the standing weighing scale and take 3 measurements as well. And the weight will be calibrated nearest to 0.1 kilogram. Okay. The next one is the occipitofrontal circumference or the head circumference. So we use the flexible measuring tape. So which part of the head that we'll measure is actually the part that will cover the occiput or frontal bone, or we can say it's above the ear and above the eyebrow. It's measured in children up to 2 years old because in 3 years old, the patient or the pediatric patient is considered, or the children is considered has the biggest head circumference unless they have certain issues. And occipitofrontal circumference also need to be done in older children with abnormal height and weight. And we do repeated measurements, and we'll pick the largest value. So macrocephaly or big head will occur when the readings or the measurements will be above 2 standard deviations above the mean, and the microcephaly or small head will be the less than 2 standard deviations below the mean. And we need to make sure that the occipitofrontal circumference or FC can be affected if the children has thick hair, or if the children have the cranial bone deformations or hyperostosis. This is this example of the graph that we plot by age and weight. So it's difference between the boy, the girl, and also difference between the preterm baby. And we have separate graph between the weight over age, length over age, and also we have the head circumference of age and some other. So I guess that's all. Do you guys have any questions?
Actually, the way you measure is another thing, is important thing. And which graph to plot is another thing. And how to interpret the graph is another thing by itself. Because plotting the graph anyone can plot, tapi interpreting the graph is quite challenging. Not everyone can interpret the graph. And actually, a lot of medical students, a lot of doctors are actually lacking of the skill to interpret growth chart, which is very important chart. Because you use it to diagnose, stunted, overweight, obesity, all are diagnosed using growth chart. And you need to know lah. So macam ni you plot? Using cross ke, using dots ke, using circle ke apa?
Using dots.
Okay, remember using dots So I don't want to see anyone using circle. Or using circle ke, using cross ke untuk plot growth chart. Because it's a fail lah, it's a fail. Because later dalam exam, we can always put growth chart, plotting and interpretation. Okay, okay, ada questions? Okay, next. But we're going to be quick, tapi if you got any questions kan, make sure you ask tau. Make sure you ask. Okay, I want you guys to benefit from the presentation. Okay, because I'm not going to benefit. Definitely I'm going to learn of course lah. Tapi the one who's going to benefit the most is you guys. So ask questions, okay?
Can you guys see my slides and hear me as well?
Yes.
Okay, thanks. Assalamualaikum warahmatullahi wabarakatuh. I am Putri Shata binti Azlan, 1875-20, and I'll be presenting two procedures. The first one is lumbar puncture in pediatrics. So the definition of lumbar puncture is also known as spinal tap, and it's a procedure in which a spinal needle is placed into the subarachnoid space of the lumbar region to remove a sample of the cerebrospinal fluid or CSF for diagnostic or therapeutic purposes. So the indications of which are for patients with suspected meningitis or encephalitis, intra-apical chemotherapy for oncology patients, and selected patients who are investigated for neurometabolic disorders. And the contraindications of these procedures are as listed below. So for patients who have cardiorespiratory instability due to the lateral recumbent position that they are put in during the procedure, patients with focal signs, signs of raised intracranial pressure or ICP, patients with coagulopathy, thrombocytopenia, or if there's a local infection at the site of the lumbar puncture, and if it causes a delay in starting antibiotics. For the complications of these procedures, is headache or back pain following the procedure, which is the most common complication, cerebral herniation associated with raised intracranial pressure, bleeding into the CSF or around the cord, as well as infection. So for the preparation, we start with evaluation. We evaluate whether the patient is fit for the procedure. So we screen for any contraindications before the lumbar puncture, which I've mentioned before. Monitor the oxygen saturation and respiration, as well as the heart rate during the procedure. And appropriate cultures and antimicrobial therapy should be done prior to neuroimaging. For the counseling, it's very reassuring that we give a clear explanation of the urgent indications and details of the procedure to the parent's guardian or parents, as well as getting a written informed consent. And it's helpful for the older children and the adolescents to practice the position that they will assume for the procedure. So these are the list of equipment, noting that this is the spinal needle used, 20 to 22 gauge needle with stylet, and the length of which varies according to the age of the patient. So for the procedure, we start with giving sedation and applying local anesthetic like lidocaine. And for the next step is positioning. This is very important because there is two positions: it's lateral recumbent or sitting position. And this is and we need to monitor the oxygen saturation continuously. The third step, we need to visualize. This is basically finding the point to puncture the skin. So we need to visualize a vertical line between the two highest points of the iliac crest and its transection within the midline of the spine. So we use, for pediatric patient, we use L3 to L4 interspace. Next, we need to clean the area using povidone iodine and 70% alcohol. Drape the puncture site. Next, gently puncture the skin with the spinal needle at the identified mark and point it towards the umbilicus. Gently advance the needle a few millimeters at a time until there's a give. So this give is basically a change in resistance on entering the dura mater. Then withdraw the stylet and check for the backflow of the cerebrospinal fluid. Stylet is basically it converts the needle, the hollow bore needle, into a solid one so that it doesn't displace the skin when we puncture it into the CSF. Then for usually patients more than 2 years old, we measure the opening pressure by attaching the needle to a manometer. After that, collect the CSF in designated bottles, usually 3 to 4 or 4 to 5. And then gently withdraw the needle, spray with upside, cover with gauze and bandage. Then lastly, ensure that the child lies supine for the next 4 to 6 hours to minimize the post-procedural headache, and continue monitoring the child until they recover from sedation. So this is the procedural video. So we give a sedation and local anesthetic and then positioning. So this positioning is the lateral recumbent position. So visualize the vertical line between the two highest iliac crests, and then the midline of which is the point of puncture, which is the L3 to L4 interspace for pediatric patients. Make sure to also have somebody to hold the baby in place. This is the needle used, 22 gauge, 1.5 inch for this patient. Having a person to hold the baby in place, position that patient during lumbar puncture. So we clean the area with aseptic technique, so povidone iodine and 70% alcohol. And then we drape the area, the puncture site area. And then we gently puncture the skin at the identified mark. Make sure it's make sure that it's towards the umbilicus, because if it's perpendicular, it's more likely to hit bone. So gently advance until there's a give or change in resistance. Remove the stylet, check for backflow, and then collect the CSF in designated bottles. Gently withdraw the needle, spray outside, cover with bandage, and ensure that the child lies supine for the next 4 to 6 hours. And then monitor the patient until they recover from the sedation. So these are the infographics. So this is the sitting position, having somebody holding the baby in place at the same time. This is the lateral recumbent position that I've shown before. This is the YouTube link of the video previously, and this is basically the site of lumbar puncture. These are my references. That's all from me. Thank you. Are there any questions?
I just want to add, okay, so in order pediatric, it's easier to do it sitting, sitting position. So just give a pillow to the child, ask him or her to hug the pillow and sit forward, bend forward. And usually the best is tak payah sedate, tapi most of the time we need to sedate lah, because the child will be struggling. Okay. Anatomy of the spinal cord is very important. Where it terminates, the filum terminale, the cauda equina, all are very important. Okay.
Thank you, Doctor.
Good medullary semua. Okay kan? Ada
Yeah.
soalan?
Any questions?
Complication you mentioned?
The first slide.
Oh, the first slide.
Yeah, I included indication, contraindication, and complication.
Dia ada complication actually. Dia actually about 2 more. Tapi okay lah, you baca lah nanti. Okay. Any soalan lain?
Complication tu apa yang doktor dua tu?
You can get pseudotumor lah, pseudotumor. You can get pseudotumor. I can remember the name. Dia ada name tapi pseudotumor lah, pseudotumor. And then apa yang tak ada kan? Headache, back pain, infection, bleeding, herniation. Tu juga yang I can remember. Problem with the pseudotumor or tattered cord kan. Tattered cord can also be one of the complication. So what happen at the side of your puncture kan, when you withdraw, sometimes the cord can actually stuck there. So the child won't have any problem, but later on when the child grow, the cord will stuck at the area. Dia jadi apa? Macam adhesion lah, dia macam adhesion. So this will actually leads to neurological findings later on bila dia besar. So tattered cord syndrome lah, dia macam tattered cord syndrome. Macam tu aja tattered, rasa macam salah je. Macam TE something. Tak apalah, I check lah, I pun tak pandai sangat English.
Okay, thank you, Doctor.
Tattered. Okay. Any other question? LP is actually quite easy. I personally think LP is quite easy lah compared to line apa IV Banula or blood taking. I prefer LP lah. Unless kalau in fat guy, fat boy, it'll be difficult. Okay. I think it's easier. Okay. Analysis we're not going to cover here. Boleh proceed lah dengan next presentation.
Okay, so for the next procedure is pediatric peripheral IV cannulation. For the introduction, the definition of peripheral IV cannulation is basically a cannula or catheter is inserted into the small peripheral vein to provide venous access, just like I've illustrated here. So the indications of which are for blood sampling, delivery of intravenous fluid, medication, and blood components, as well as total parenteral nutrition and hemodynamic monitoring. The contraindications as listed is infection, phlebitis, which is the inflammation of the vein, sclerosed vein, burns, traumatic injury, and surgical procedure. For the complications, hematoma or bleeding, thrombophlebitis after a few days, and extravasation that can lead to soft tissue injury resulting in a limb or digital loss and loss of function. This is this complication is very concerning because it can occur in neonates where digital ischemia, partial limb loss, nerve damage, and contraction of the skin and across the joints. So for the site, there are 4 sites: upper extremities, lower extremities, and scalp, as well as external jugular vein. So for the upper extremities, usually a dorsal vein of the hand, but we can also use cephalic vein, basilic vein, median capital veins in the forearm, all as illustrated in this picture. Lower extremities, dorsal arch, as well as great saphenous vein. And for the scalp, we can use, but it's less desirable because we have to shift the baby's head, and then the parents might be afraid because there's a needle in the head. And the small superficial veins of the scalp are rarely used during CPR, cardiopulmonary resuscitation, but may be helpful in less urgent situation. And lastly, external jugular vein. It can be used, but it cannot be used as a primary site during resuscitation of patients with airway compromise. There's a concern for cervical spine injury or respiratory failure because it requires an extension and rotation of the neck. For the equipment, these are the list of equipment used. Next is the procedure. So the first part, we need to identify the vein, secure the identified limb, and apply a tourniquet proximal to the limb. After that, next step is we put topical anesthetic, can apply with occlusive plaster or 1 hour earlier, or spray with alkyl chloride for a short procedure. Then we clean the skin with alcohol swab, puncture the skin and advance the needle or catheter in the same direction as the vein at a 15 to 30 degrees angle. Then the catheter is advanced further a few millimeters, and once the blood appears on the hub, we draw the needle slightly while advancing the catheter over the needle. After that, we remove the tourniquet and flush the catheter with heparinized saline. Secure the catheter and connect it to either a rubber band or an IV drip. And lastly, immobilize the joint above and below the side of catheter insertion with restraining board and tape. Noting that if we were to accidentally cannulate the artery, there will be pulsatile backflow of the blood. And what will happen is that we need to, what we do is the catheter should be removed and apply pressure at the site of cannulation until the bleeding stops for a minimum of 5 minutes. And then after that, a different site for peripheral venous access is obtained. So this is the procedural videos. So this one is basically he's applying a tourniquet and then identifying the vein. So this is the dorsal vein. Applying alcohol swab, between the area with alcohol swab, puncture the skin, advance the needle or catheter towards the vein at 15 to 30 degree angle. Once the blood appears at the hub, advance the catheter over the needle. After that, We remove the tourniquet and flush with hepariniseline. Or flush with hepariniseline. Make sure to secure the catheter and connect it to a rubber band and IV drip. And this is basically the step in which they immobilize the joint above and below the side of catheter insertion with lots of restraining board and lots of tape. Restraining board and tape. So these are the infographics. These are the list of peripheral IV catheter chart that we use. So for rapid infusion, we use orange, gray, and green. But for normal, what we use for most infusion is purple, yellow, blue, as well as purple, yellow, blue. The pink one for rapid infusion. So the different colors, they correlate to different gauge size as well as the diameter. So the smaller the gauge size, the bigger the diameter. So that's why the rapid infusion are the ones listed above: orange, gray, green, and pink. But for normal infusion, blue, yellow, purple. So newborns and infants, we use a 22 to 24 gauge. But for older children, we use a bigger diameter, 18 to 20 gauge. So if you can't see the vein for babies, we can use transillumination of the palm with high-powered cold light source. So we can actually easily see the vein now because the baby's hands are very chubby. After that, this is the link of the YouTube video for the previous video. These are my references, and that's all from me. Thank you. Are there any questions?
Okay, any questions? Any questions? Ada tak soalan? If not, then I think this one you need to see lah, baru you understand. And not many people pandai. To be honest, I'm very not good. In fact, I'm very stupid in IV line session. Cuma one thing, I noticed the video kan, they use tourniquet on baby kan. We don't use tourniquet on baby lah usually. Because the problem is, if you use tourniquet kan, the baby vessel is very small and they are very collapsible lah. If you use tourniquet, it will total collapse. So you won't get blood. You'll get empty, like empty puncture. So usually we don't use tourniquet lah, like proper like rubber band and tourniquet. Okay, you just hold it lah. You can ask someone else to actually hold it. Hold the hand, okay, the wrist, for example, using the thumb and also the index finger, okay, to form your like finger tourniquet rather than like tourniquet rubber band, which is inflexible. Okay, next. Good.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm Muhammad Zakam Rahman. We're sharing about the long percutaneous lung infection, or we call this as PICC, percutaneous peripherally inserted central catheter. Okay. Okay. Well, so what is central long line? It is a premicas or a catheter, which is a plastic tube about 10 to 30 cm, inserted into a very large vein that involves the upper or lower limbs, and sometimes which rarely involve the scalp, into a large vein that direct to the heart through the superior and inferior vena cava. Okay, so the indication of PICC is for the parenteral nutrition administration, medication and hypertonic solution, and the frequent and for the frequent blood taking condition. And the contraindication it includes the if the site of puncture have the infection, whether it is systemic or localized, sepsis or dermatitis, okay, any blood disorders and non-venous thrombosis. So the insertion sites is involving three parts: upper limb, lower limb, and the raleigh scalp. It involves the medial or lateral antecubital vein to the basilic or cephalic vein. It may involve the long saphenous vein at the medial malleolus, and the last one, the rarely used, is the superficial temporal vein, the last choice. So insertion length, upper limb, we use the antecubital vein to the level of sternum, at level of second intercostal space. Lower limb, from the great saphenous vein up to the sternum level, and the scalp we insert from the insertion site to the sternum level. Okay, and then these are the equipments that we will use: the surgical tape, the tourniquet. But as doctor said, in pediatric patient, we do not use the tourniquet. Okay, and then we have the invasive BP monitoring unit, because we must keep on monitoring the patient BP and lignocaine, gauze, tegaderm. Or tegaderm is a brand which is a dressing. We need guide wires, alcohol swab, syringe, and permicast, the catheter. Okay, and this is the procedure. So the first one, basically, prepare all the equipment, sanitize our hands, and identify the patient. Then we wash our hands again, put a sterile gown and gloves, measure the length of the tube based on the length that I shared earlier. Swab the insertion site with the chlorhexidine or alcohol swab, let it dry for 1 minute, apply tourniquet. Okay, insert the introducer followed by guide wire. When there is a boost of blood flows in the introducer, insert the permicast into the desired until the desired length reach. Flush with saline. If resistance occur, remove the permicast and repeat until there is no resistance. Okay, because the resistance may indicate that we have punctured maybe the vein or the myocardium. Okay, split the permicast and lift out the line carefully from it and apply pressure using the sterile gauze. Apply gauze and the dressing. And then we must perform X-ray to confirm the permicast line. Then this is the complication. It may be vein perforation, cardiac tamponade, infection, or thrombosis upon insertion. So this is the X-ray of the heterogenic cardiac tamponade. See, you can see the line here. Okay, so this is the YouTube link that I attached. You can watch later. So this is my references. Okay, you can scan here. And okay, thank you. That's all. Any question?
Any question for PICC? So how do you measure actually the length of PICC?
We measure to it based on our sites of insertion. If we at the upper limb, we choose from the site of insertion until to the second level of the intercostal space, a level of sternum. Then the following like this.
So until level of sternum.
Sternum, yes.
Okay, actually PICC is very difficult to insert. It's very difficult, especially it depends on the size that you're going to use. Double lumen is much more difficult. The problem is with the current way we inserted the PICC, where we call it direct measurement, because we measure directly from the site of insertion until the sternum. What happens is some babies, because we don't actually consider the depth of the skin, the depth of the adipose tissue, the flexure, the skin flexure, the joint. So what happens is a lot of time we need to readjust after insertion. So after insertion, we confirm the placement from X-ray, and a lot of time we need to adjust, and this cause problem because adjustment of PICC is dangerous because this is where you will introduce infection, because you need to really, pull the catheter back. So this is where the manipulation will introduce infection, will introduce leads to thrombus, dislodge, and also some other problems. That's why recently there's one researcher in Taiwan who proposed with a mathematical formula based on the weight, or the length, and also the parameter lah, body parameter of the child rather than direct measurement. So actually I myself and our team in USM and also in UIA, we are actually planning to conduct a study, a trial to compare both methods. Hopefully it works, and then maybe later on in future, if the formula found to be superior, then maybe later on in your future practice, we're no longer going to measure the anatomical landmark, but rather we're going to use mathematical formula. Who knows? But be open for the option. Okay. Any other questions? And usually this will be performed by specialists or very senior doctors. Now you don't ask. We don't allow junior doctor to actually perform this because it's very, very difficult. Okay. And remember, when you do like difficult procedure like this or painful procedure, you have to consider giving anesthetic. So in baby, we usually give dextrose, and of course you need to give like morphine, things like that to calm and also for pain. Okay. Other questions? Okay.
Okay.
I will be the next presenter. Iza, can you present the slide?
Oh, sure. Wait.
Alright, thank you, Iza. Okay, Bismillahirrahmanirrahim. I am Atika and I will be presenting about nasogastric tube insertion. Next slide. Okay, so basically nasogastric tube is a long, thin, hollow tube which is passed through a nostril of the nose into the throat and down into the stomach. As for the indications, the most important one is the delivery of the medications, providing hydration and enteral nutritional supports. As for the contraindications, infant, child, or young person with a basal skull fracture, maxillofacial abnormalities, or nasopharyngeal abnormalities are contraindicated. For this patient, oral incision, or known as the orogastric tube, is indicated. Next slide. Okay, so these are the equipment that need during this procedure, and table 1 shows that different size of nasogastric tube for different age of the pediatric patient. Next slide. Okay, for the procedure, first of all, after you have explained the procedure and gain the consent form, you estimate the length of nasogastric tube that need to be inserted and mark on the nasogastric tube. For infant, the measurement would be from the bridge of the nose to the earlobe and to a point halfway between the xiphoid process and the umbilicus. For the older children, which is more than 1 year old, the measurement would be from the bridge of the nose to the earlobe and down to the xiphoid process. Next, you mark on the nasogastric tube from the previous slide, please. Okay, and next you position of the children. For infant, the infant should be wrapped and put in a position of supine with a slight head up position.
For the older children, they should be in a comfortable sitting position held by the caregivers or the healthcare providers. Next slide. Okay, next you dip the end of the nasogastric tube into about 3 inch of the lubricants, and you put the tube slowly into the nose, where you should make sure that the nasogastric tube is parallel to the palates and the nasal septum. And then you aim the nasogastric tube towards the earlobe. So using a gentle pressure, keep inserting the tube until the tape mark placed on the tube reaches outside of the child nose. If let's say the tube does not go in easily, where the children might experience cough, gags, or chokes, so the tube should be removed. Reposition the children, lubricate the end of the tube again, and try the procedures again. There is a tip where the tube may go down easier if you have the infant suck on the pacifier, or the older children drink small sips of the water. And next you check the placement of the tube. This I will explain later. After the tube is in place, carefully remove the guide wire and use the free end of the tape on the child nose to keep the tube in place. Next slide. Okay, so how to check the placement of the tube? So after you have made sure that the pen, tape, or documented centimeter mark on the tube is visible right at the nostril, so you can go for the auscultation. And for auscultation technique, the about 5 milliliter of air is flushed into the tube, and then you should hear the whoosh sound using stethoscope. This stethoscope is positioned at the left hypochondriac region. Other than that, you can go for the aspirating gastric contents technique, where after you flush the air, you pull back the plunger of the syringe to draw about 2 milliliter of gastric contents, and you test the gastric contents using pH indicator strips. And pH equals to 5 or below than 5 should tell you that this tube is in the correct place. So basically, in adult, we check using the X-ray. But for the pediatric patient, the X-ray use is questionable. So because of the side effect and so on. So that's why you use these techniques. Okay, next slide. Next slide. Okay, for the complications, so the main complication of this procedure is the aspiration, where the gastric content might aspirate to the lung and cause aspiration pneumonia. Next is the tissue trauma to upper gastrointestinal tract and intracranial placement in children that have facial fracture. This is caused by blind placement of the nasogastric tube. Okay, that's all from me. Is there any question?
Rasa macam dah ada orang present kan nasogastric tube? Ke tak ada?
Not yet.
Oh, I'm confused lah. Okay, okay, ada soalan?
One question. Do we sedate the child during this procedure?
I think no, because just a simple procedure. As you can see in the picture, that the child can be positioned during can be in a comfortable position, or in the supine with slight head up position.
Okay.
Because I don't find any use of the anesthesia in the procedures that I've read.
Okay, thank you.
Actually kan, you don't give sedation. In fact, patient kalau aware lagi better. You can, the easier way is actually you can give patient water kan, bagi dia water sikit. So they sit up, you insert the tube, and then ask, kalau ni budak besar lah, kalau baby maybe difficult lah. Tapi kalau budak besar, you can ask them to swallow. So bila dia swallow, dia akan swallow sekali dengan the tube. Because if you that's safer way, because if you are swallowing, once we during swallow mechanism, your glottis will close your epiglottis kan, so your glottis akan close your epiglottis, so there's less risk untuk aspirate, faham tak, untuk lung punya intubation lah, so-called intubation lah. So that's better way. So kalau adult atau older children, you can waktu insert, you boleh bagi dia air, so dia minum, and then you masuk, because it will go into the stomach. So we don't actually sedate. And besides, kalau you sedate deeply, if the patient lost dia punya gag reflex kan, then it will be dangerous. So kalau you masuk lung, you won't know that you are actually entering the lung. Tapi kalau patient awake, dia boleh ada gag, so you tahu bila masuk, dia ada gag atau dia ada cough reflex, cough reflex, then you tahu you are actually entering the trachea. Okay, ada any questions?
Should I proceed, Doctor?
Yes.
Okay. Wait. Okay. Can you guys hear me and see the screen?
Yes, we can.
Okay. Thank you. Okay, I will continue with two procedure, which are venipuncture and BP measurement in pediatrics. So first we go with venipuncture. Okay, venipuncture is a procedure where we take blood sample and also to introduce fluid, medication, and also blood components. So the equipments are as follows. So later when we go through the steps in procedure, we will take note of the usage of the equipments. So the preferable site is at the antecubital fossa, at the site where the arms bends at the elbow, and the preferred vein is the median cubital vein, as circled in green here. So there are other veins that can be used but not preferred, such as a cephalic vein, because it has tendency to roll. And there are veins that should not be used, which is a basilic vein because of these reasons, close to brachial nerve and artery. So we do not want to touch this nerve and artery. The hand and the wrist vein can be used when the arm veins cannot be located. So the steps. Okay. So we use a wing steel needle, usually a 23 or 25 gauge with an extension of butterfly. So we keep this tube and the needle separated until the needle is introduced into the vein. So we prepare the equipment, we perform hand hygiene, and we may ask for assistance from the parents or any person in the room to immobilize the baby or child so that the child won't be moving around as the procedure being conducted. And okay, here it says a tourniquet, but doctor said in a previous presentation that we just need for the assistant to hold the arm for us when we do the procedure. So we ask them to hold at about 2 finger width above the side. So that's when we ask the parents to hold it for us. We put on the glove and we prepare the needle. So we attach the wing infusion set to the end of the vacuum tube and insert the collection tube into the holder. And we remove the plastic sleeve from the butterfly. And then we identify the site, like I said before, at the antecubital fossa. And we, in PITS protocol, it says that we might also put topical anesthetic an hour earlier or spray with ethyl chloride in a short procedure if necessary. So after that, we disinfect the site with alcohol swab and allow it to dry for a moment. And then we kind of like stretch the area where we want to insert the needle so that we can observe the vein more clearer. And we advance the needle. So usually in a younger patient, in child, since there is not much adipose tissue, we can just insert the needle nearly flat, because in adult we need to first insert it more vertically because of the adipose tissue, and then after the needle is in the vein, we flatten it. But in children, no, 15 to 30 degree angle or nearly flat is good to go. So then we push the vacuum tube completely into the needle and we wait, and when the needle is already in the vein, we should be able to observe the blood flow into the tube. And after it is full, or the vacuum is full, so we can withdraw the needle. But if we need to fill a multiple tube, we carefully hold the needle into place, make sure the needle is not moved, and then we just change the tube. After the required amount has been collected, using another hand, so this hand we hold the needle, using another hand, if we apply tourniquet, we release the tourniquet. Yeah, after that, we place the dry gauge over the venipuncture site, like that. So we ask the parent to continue apply the mic pressure, remove the butterfly from the vacuum tube holder, dispose it in a sharp container, and dispose all the other contaminated supplies. We then label the tube with patient ID and date, apply a bandage if necessary, remove gloves, dispose appropriately, and perform hand hygiene. So that's it for venipuncture. For BP measurement, so these are the indication where we need to do this procedure. As for the equipments, normally there are two types, which is a manual device and automated device. So as for the manual device, we need to use a stethoscope as well, but not for automated device. So one of the important thing when we do BP measurement is we need to use appropriate cuff size. So how do we measure it is by, the length is the horizontal part of the cuff should be 80% of the arm circumference. Meanwhile, the width should be 40% of the arm circumference. So this is very important because of if we use a larger cuff size, we might get a lower force reading. Meanwhile, if we use the smaller cuff size, we might get a false higher reading. So that's very important. As for the steps in manual BP measurement, so first we need to have the patient being more relaxed, comfortable. If the patient is crying or throwing tantrum, we might ask the parents to help with that. After that, aside from the cuff size, another important thing to know in BP measurement is that the level of the arm. The arm should be at the cuffs, where we place the cuff, should be at the level of the heart. So the patient, okay, like this boy here, this should be at the level of the heart. And then we might ask the child to slightly flex the elbow. And then we place the BP cuff. Okay, the first step is we need to determine inflation level. What I mean by inflation level is that when we want to inflate the cuff, to what extent do we want to inflate it? So not necessarily we inflate until the 300, right? So to what extent? So this is what meant by inflation level. So what we need to do is, okay, the first picture here shows, so after the cuff being put on, we palpate the radial artery and we inflate rapidly until we feel that the radial pulse is disappear. So that's point we need to take note. That's an estimated systolic BP. And then we add 30 millimeter mercury to it. So let's say 130, we get when the radial pulse disappear, we add 30 to 160. So we need to pump until 160. Okay, then we deflate the cuff, wait for 15 to 30 seconds. Okay, then we start the real procedure to determine the systolic and diastolic BP. So we put on stethoscope, we place it at the brachial artery here, and see here, step number 7, we inflate the cuff to the predetermined inflation level. Like I said just now, 130 plus 30 here, become 160. So we inflate all the way through to 160, and then we deflate slowly at the rate of 2 to 3 millimeter mercury. And this is the part where we need to hear the sounds of the correct cough sounds. Okay, when we deflate the cuff, at first we will hear no sounds at all. So then we wait until we hear the tapping sounds or the phase 1 of correct cough sounds. So this indicates systolic BP. And then we wait for a bit, there will be swishing sound, there will be knocking kind of sounds at the phase 3, and then the sound become muffled and switching. So this 3 is not our concern. Our concern is when the sounds disappear. So that indicates a diastolic BP reading. So tapping sound, systolic, and then when the sound disappear, diastolic pressure. So we take note of the sounds. So this is how it sounds like. Okay, first we wait until we hear tapping sounds. So that's indicate the systolic sounds, systolic BP. And later, like a swishing sound, phase 2. And kind of like a knocking sound, phase 3. And the sound will become muffled and have a kind of a swishing quality, which indicate phase 4. And then we wait until the sound disappear or cease. So that when we note that it is a dystolic BP. Okay, then we deflate the cuff rapidly. So we measure the reading to the nearest 2 millimeter mercury, record the BP, use, position, and the cuff size used. And we will, if we need to repeat the measurement, wait for another 2 minutes before we start again. Oh. Okay, next. Okay, for automated device BP measurement, where we usually use this in a clinical setting because it's more easier and direct. So again, we have the patient sitting comfortable and relaxed. The position of the arm is very important at the level of the heart, and we place the cuff on the arm. Again, the size should be appropriate, and we start the machine and we wait until the machine gives us a reading of the systolic and diastolic BP. So that's all. I record the BP like just now, and if we need to repeat, wait for another 2 minutes before we start again. So that's all. Is there any question?
Okay, good. Any questions? Cuma ada satu issue. I think same issue with your colleague yang last week. Because your presentation you still use the Vacutainer, kan? Am I right?
Yes.
So because is that how pitch protocol teach you guys? I mean, is it how in pitch protocol?
Vacutainer.
Cuba tengok you punya apa tu? You punya vein puncher. Use butterfly and Vacutainer.
This one?
Yes. Cuba tengok you punya Vacutainer. Gambar tadi. Kan Vacutainer kan? Siapa yang I cakap last week? Is it last week ke last 2 weeks? Saya tak ingat dah. What method we use in pediatric? In Malaysia lah. In Malaysia, this is not the ideal lah, of course. Tapi in Malaysia lah.
Tak guna needle yang with butterfly macam ni ke?
We rarely use butterfly. Okay, we do have butterfly. Occasionally we use. Kalau susah sangat, we use butterfly. But kalau banyak saya kita guna butterfly lah. Kita nak ambil banyak saudara. Because it's secure in place. Tapi usually what method we usually use untuk blood taking? Kita guna drop method kan, I've mentioned. Especially in blood culture. Tapi even in normal venipuncture pun kita guna ni lah. Kita guna drop method. Where you actually use normal needle and then you drop the blood into the tube. Kan? Remember tak I cakap?
Macam buat lambar panca tu dia kita biarkan.
Similar to like lambar panca, yes. We use drop method. We rarely use satu sebab it's very expensive tau. Butterfly is very expensive. Satu butterfly is I think RM8. The smaller, the more expensive. And then secondly, we don't have Vacutainer in Malaysia. Our tube is not Vacutainer tube. Because Vacutainer tube, you tak buka tau the cap. You just cocok je. So itulah tapi it's okay lah. It's okay. I think later your friend akan tunjuk bukan you, I thought your group kan yang patut present venipuncture kan? Yang I suruh repeat balik.
Venipuncture
Blood culture, sorry. Blood culture kan?
Dia akan present lepas ni.
Okay. So I hope he will amend it lah. Tapi itulah, remember please present something that is practical lah, something that we actually use rather than something theoretical or the ideal, because it's not always ideal lah, especially in Malaysia. Okay, anyway, so boleh proceed lah with the next one.
So doktor just nak clearkan balik, kita tak guna lah yang vacuum tube with butterfly ni. Kita
we don't.
Drip apa tadi? Drop.
No, we don't. We use drop method or we use syringe out. So basically kita guna syringe attached to needle. So we puncture like large vein lah, macam backward vein kan, rather than basically kita jarang guna lah. And then kita aspirate.
Okay.
Tapi that's in older children. Kalau young children or infant, kita guna drop method. Okay, good.
Thank you, doctor.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So I'll be continuing the previous blood culture and sensitivity. So this what I have seen before, and so this year what's new here is that we talked about before regarding the site where we need to take blood sample, which is for all the children or adolescent, we take from the medial cubital vein in antecubital fossa. But for neonates or infants, we usually take from the cannular hub through peripheral cannulation. So this is the equipment. So what's new here is the pediatric blood culture bottle, which is the pink color. It is an aerobic blood culture bottle because usually for children who is less than 28 weeks old, they usually have aerobic infections. So moving on with the procedure itself. So we inform the patient guardian about the procedure and gain consent, and we prepare some toys if our patient is small children to distract them during the procedure later. Then as usual, perform hand hygiene and prepare the equipment on trolley. Don gloves and apron, then remove the blood culture bottle cap using the thumb to maintain the aseptic manner. Then clean the bottle, the lid of the bottle using a cleaning swab and allow to dry. And next, if the patient is do not remain still, we may ask the help from the parent to hold the children or to immobilize them in this position. And then apply tourniquet for children who is for older children or adolescent, but for younger children or infants or toddlers, tourniquets may not be applicable as what I have mentioned before. And then use a cleaning swab and then scrub down the puncture site in a spiral motion for about 2 to 3 scrubs and allow to dry, and use different swabs for each scrubbing. And then perform venipuncture using wing infusion set with the adapter if our patient is adolescent or young or older children, or use peripheral cannula insertion if for infants or neonates, or we can even use drop method, which is not being shown here actually. And then as usual, and then proceed attach the blood culture bottle to the adapter and allow the culture to fill to a desired volume, usually not more than 0.5 ml for neonates or infants, and for older children maybe can take about 1 to 3 ml, or for adolescent can take as same as adult, which is 20 to 30 ml. And then release tourniquet and apply sterile gauze at the venipuncture site and slowly remove the needle. And then apply cotton ball at the venipuncture site and ask the parent to apply mild pressure. Then we apply skin dressings. Then dispose our gloves and sharps material in appropriate sharps bin and disposal bin. Then label the bottle with patient's detail and place appropriately in biohazard bag before sending to lab. And last but not least, don't forget to thank the patient. And important, and that's all from me. This is my references.
Any questions, guys? Any question? Tak ada soalan?
Tak ada.
Okay, just one point lah to mention. Just now you mentioned you can ask the parents to help to hold the child, kan? Actually, you should not. Okay, the procedure should be done away from parents or family members. It should be done in a specific room, procedure room, because you don't want the parents to traumatize or they tangkap video and then make it public. You know, nowadays parents are some are idiots. I know most of them are not, but there are some parents who are idiots. And so do doctors juga lah. Because we are lacking of communication skills, as you know. So there's a lot of miscommunication between parents and doctors. So definitely do not ask the parents to actually hold, unless if you are alone, no assistance, and your nurses are lazy or they're just not helpful, then you may need to ask the parents. Okay, kan? Lepas tu, usually blood culture is always, you always need two people to perform, especially one, because once you sterile, you are not supposed to touch the bottle, kan? So you need someone to hold the bottle, to open the lid, and then for you to actually to scrub the top of the lid. Itulah. That's all lah. Ada soalan?
Doktor yang parents tak boleh ada tu apply to all procedures ke?
All procedure.
Okay.
I tak tahu, you guys, maybe some of you dah ada anak, I tak tahu. Tapi kalau I myself, I tak nak tengok anak I kena cucuk. Okay. Okay dah, tu lah. Selalu I tak cucuk pun, biasa my wife yang akan cucuk. Saya tak suka cucuk orang. Okay, anyway, so continue next. Ada lagi ya?
Last one, Doctor.
Oh, good. Okay.
Okay, so I'll be continue on with the electroencephalography, which is short form. Short form is EEG. Is basically test to detect electrical activity in our brain and display it in waveforms, and commonly used for diagnosis of epilepsy and so other things. And types of EEG, which is outpatient EEG, is routine EEG we usually do, and inpatient EEG, which is required patient to stay overnight, and ambulatory EEG is where patient can take home. And this is a 1020 international system. This is a standardized system used to place the electrodes on the scalp of the patient. So the way we do it is that first we need to find the nasion, which is the bridge of the nose, as well as the inion, the occipital protuberance. Then we take a measuring tape, and then we measure from the inion from the nasion to the inion. Then let's say that mine is around 43. So we measure 10% of 43 is 4.3. So then we measure again. Then we use a washable marker or a wax crayon to mark. And then we proceed with 20%, 20%, 20%, and 10%. Then after we get the sagittal line, we continue on with the horizontal line, which is we start from the preauricular point here, which is just anterior to your ear. Then we take a measuring tape, then follow the same steps as before. Then consider is 40, then 10% from 40 is 4 cm, so we measure, then 4 cm, we take a again, take a marker, then mark points here, then continue with 20%, 20%, and then so on. Then we get the vertical line and the horizontal line. Next, we continue with the circumference, which the increment between the points is about 10%. So we measure starts from the where we begin our circumference, usually at T3 or at T4 points, which the points that we already marked before. Then we start to measure the F7, F8, and so on. The increment is 10% for each. Then after the circumference, we measure the parasagittal lines, which is the lines at the sides of the central line here. So we take from F1, FP1 to O1 and FP2 to O2. And then the increment between their points is 25%. Then last but not least is the transverse measurement, which is at the frontal, also at the parietal part. And basically this is just plotting the dots for the points that we have already marked before. And EEG, how the EEG is recorded is using a differential amplifier, which is a system that allows the machine to display only the differences between the two electrical waves. And montages is how the EEG is displayed. We have two montage here, the bipolar and also the common average reference montage. Bipolar montage is like in the picture. It compares between the 2 points, starting from, for example, right here, the FP2 and also F8. So it will display that. So it display here the electrical differences between the 2 points here, and then it will go on to complete as a chain, and then it will continue with another chain, and so on. Common average reference montage, it compares between one electrodes with the average of all the electrodes. Next, for preparation and steps, the child is sleep deprived or asked to lessen their sleep before the EEG test. The hair is clean and do not use any usage of ointments such as pomade and so on. And avoid give medicine as scheduled, avoid caffeine and sugar, bathroom before start because this is a long procedure. Make the child comfortable by bringing the pillow or blanket. And then the steps is we must lie the child comfortably, make sure the child is very comfortable because this is a long procedure. Then measure and mark the child's head, just like in the 1020 system. That applies skin preparations, which is we apply as adhesive solution paste that allows the electrodes to stick, as well as to enhance the detection of the electrical activity of the brain. Then wrap the head. Then we finish off by wrapping the head with a gauze wrap to make sure that the electrode stays in place. Then there are several activation exercises we do during the EEG. First is the fatigue exercise, which is the child is exposed to an intermittent flashing of high intense white light at the rate of 30 flashes per second. This is used to detect epilepsy induced by photosensitivity. Next is the hyperventilation exercise, which we take, which we ask the child to blow on a toy fan for about 3 minutes, because a brief, rapid, vigorous breathing may induce epileptic form discharges that may be detected in the EEG machine. And last but not least, we ask the child to sleep, because the occurrence of focal and generalized epileptic discharges can be detected in non-sleep, non-REM sleep. And in some child with difficulty to sleep, we might give sedation with chloral hydrate. And some important we need to consider for neonatal EEG. First, we need to know the conceptual age, which is the gestational age. Gestational age is the age of the baby from the mother's last menstrual period until the day he was born, and the chronological age, which is the age of the baby from his born until now. And the number of electrodes is why we need to know the conceptual age, because the development of the baby's brain is age specific. So what is normal for baby of 26 weeks old might not be normal for baby of 40 weeks old. The number of electrodes used is also reduced to consider the small size head of the baby. Then we add some electrodes, some more electrodes, electromyogram, electrocardiogram, also respiratory monitor to enhance reading as well as to reduce artifact detection. And then some recording settings such as the electrical impedance need to be lower, and the ECG is run for 60 minutes in neonates and infants compared to adults for only 30 to 40 minutes, because this is to ensure full sleep cycle in neonates is recorded. So that's all from me. Thank you.
Okay, good. Okay, ada soalan? Any questions?
No.
No. Okay, EEG is quite tough lah. So, okay dah. I rasa okay kot. Yang lain semua okay dah. Okay, tu je kot. Kan? Okay, any questions just text me. Okay, if I got time then I'll respond. Or if I cannot answer then I'll get someone else to answer lah. Okay?
Okay, doktor.
Okay lah, kita tangguh dengan tasbih kafarah. Satu nas.
Doktor,
Apa dia? Apa dia?
kena hantar ke slide dekat doktor?
Yes.
Lepas tu nanti kalau nak hantar yang dekat doktor tu, slide tu kena include ke semua yang detail-detail like complication, indication?
Tak, ya, you just hantar apa yang you present.
Okay.
Okay. Okay lah. Bismillahirrahmanirrahim. Asyhadu an la ilaha illallah. Okay, assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum. Thank you, doktor.
Thank you, Doctor.
Thank you, doktor.